Imagine a patient sitting in your clinic, presenting with chronic headaches. You can diagnose the biological cause, the pathophysiology, which we call the disease. But that diagnosis alone doesn't tell you how this condition affects their sleep, their ability to work, or their anxiety about what a headache might mean. That unique lived experience is the illness. To treat the person effectively, we have to bridge the gap between the two. This diagram shows the Calgary-Cambridge framework. Instead of a traditional checklist, it offers a structured communication process. It organizes consultations into 5 sequential stages, flanked by 2 vertical arrows. Providing structure and building the relationship are continuous skills applied throughout the entire interview. Applying these continuous pillars ensures that the clinical data and the personal context are captured together. This structured approach helps identify the patient's specific concerns early, reducing the risk of a miscommunication that could derail the consultation. Let's apply this to our headache patient. The first stage, initiating the session, actually begins before you enter the room. Mentally prepare, review the chart, and minimize distractions. Once inside, establish a collaborative agenda right away. If you uncover all their concerns early, you avoid the door handle question, when a patient brings up their most urgent issue right as the appointment ends. A highly effective way to do this is with a simple, open-ended question. Before we begin, what would you like us to cover today? With priority set, you move into gathering information. This is where the framework employs its most crucial concept, the parallel search. This split-screen graphic illustrates the 2 tracks you must investigate simultaneously. On one side, you explore the biomedical elements of the headache, symptom triggers, location, and timeline. On the other side, you explore the patient's perspective, their fears about a potential tumor, how the pain affects their job, and what they expect from this visit. Next is the physical examination. There is a common misconception that communication pauses when the stethoscope comes out. It shouldn't. You need to explain what you are about to do, seek permission, maintain their dignity, and share appropriate findings in real time. By weaving these first 3 phases together, you gather the complete clinical and personal context. You now have the full picture required to formulate a treatment plan that the patient will actually accept and follow. Your physical exam reveals tension headaches. However, you know from the parallel search that the patient is highly anxious about taking daily medication. How do you explain the treatment plan? Pause the video here. Think back to the goals of the framework and write down 2 specific communication techniques you would use to share this diagnosis without overwhelming the patient. The answer lies in the explanation and planning phase. This flowchart shows the primary technique to avoid overwhelming your patient. Chunk and check. You deliver the information in small, manageable blocks, and then immediately pause to check their understanding, creating a continuous feedback loop. This prevents the consultation from turning into a jargon-heavy monologue. Instead, it promotes shared decision-making. Because you chunked the information, the patient has space to voice their anxiety about medication, allowing you to incorporate their preferences, like starting with physical therapy, into the final plan. Replacing a medical monologue with this type of shared dialogue makes the final management plan something the patient has actively shaped. This increases the likelihood that they will adhere to the treatment once they leave the clinic. That brings us to closing the session. Ending a consultation with absolute clarity is as vital for patient safety as a strong opening. A safe closure requires 4 steps. First, summarize the discussion. Second, confirm the agreed-upon plan. Third, do one final check of their understanding. And fourth, provide specific safety netting advice, ensuring they know what to do and who to call if symptoms worsen. Keep in mind, the Calgary-Cambridge framework is a flexible guide, not a rigid script. You adapt it to the specific needs of the emergency room, the ward round, or the outpatient clinic. Its real power is providing a shared, objective language to practice and assess clinical communication. This is the expanded framework. It breaks down those 5 broad phases into specific, actionable process skills, like picking up cues and using internal summaries. You can download a high-resolution version of this diagram in the video description to use as a clinical cheat sheet. By systematically marrying diagnostic methods with these structured communication skills, healthcare professionals can build a more accurate clinical picture while strengthening the partnership required for effective care.